that, we will move over to our headliner presentation today. We have two members of the VA suicide prevention team here with us today, and I would like to introduce both of them, and then I will just hand it over to them. The first social worker I'd like to introduce is Melissa Weber. Melissa is a licensed clinical social worker. She worked in inpatient mental health settings for 10 years prior to joining the VA in 2016. She started her VA career in the Psychosocial Rehabilitation and Recovery Center, doing therapy with veterans who live with severe mental illness. She moved from, this is the best VA acronym, PRRC. She moved from the PRRC program to the General Mental Health Clinic, where she did psychiatric assessments for enrollment for several years, and she now works in the suicide prevention program as a suicide prevention coordinator. So thank you, Melissa, for being here. And the second social worker we have joining us from the suicide prevention program is LaWanda Lambert Gurton. LaWanda is a social worker with over 2 decades of experience being a leader, advocate, trainer, and community organizer. As a licensed clinical social worker, she educates individuals and communities on the mental health challenges faced and community resources available to them. Her practice background is in leadership and administrative social work, program development and design, community organizing and building nonprofit sustainability, and her passion is serving individuals in communities that have been marginalized. Mrs. Gurton works with several coalitions across the state of Indiana. She is very involved. She has the honor of serving as the chair of the Black Suicide Prevention Task Force, which was initiated under the leadership of Governor Eric Holcomb. LaWanda now serves as the Community Engagement and Partnership Coordinator for Veterans Affairs, working in the community in partnership with the existing coalitions and organizations that aid communities in establishing best practices, evidence-based practices in suicide prevention in Indiana. Thank you so much, LaWanda, for being here today. With that, I believe I have successfully made both of you as co-host, so I am going to stop sharing my screen so that Melissa, you can take it away.
Good morning to
I'm sorry,
all.
LaWanda.
No worries. Good morning to you all. Wow, this information, I've been on here, I'm just like in awe of the information that has been shared on here. And as I was kind of like thinking I'm going to be doing this presentation, how I need to like shift a little bit with some of the information that you all have shared. I'm just like, wow, this is phenomenal. I had no idea this was all happening, Melissa. Excuse me. But now I know, right? So when you know better, you do better. So I'm going to begin to share my screen for my PowerPoint presentation. It's not a very long presentation. I was graciously invited to come and share about the work that I do with the VA and how it impacts veterans and those that have served in the military and their family members. And so without further ado, hopefully I will be able to successfully share my screen. Are you all seeing my screen? Okay, great. I'm going to attempt to try to get this to go from the beginning slideshow. It's giving me a little lag there from the beginning. And I think I am set to go, right, Liz? Bingo, great. Again, my name is LaWanda Gurton. I'm the Community Engagement Partnership Coordinator. Thank you, Liz, for shortening that bio. So we want to just talk about here very briefly that suicide prevention is everyone's business. Absolutely everyone that is on this call right now, it is our business. The fortunate thing for us is that there's all kinds of partners that are on here that have come together. I focus in on building the community engagement, but it does not mean that there's also reach veterans and their families, change the conversation about suicide, which Melissa, my coworker, is going to really give you some insightful information about. We have this wonderful community-based initiative. It's an innovative program and strategy that we have taken into the community across the state of Indiana. And so we want to continue to have suicide prevention in the face of those individuals in our community. And so I'm going to tell you a little bit about it. This community-based intervention that we actually have, it is multi-level. We got the national level, we've got the state level, and then we have the community level. And the community is where I reside, and I do a lot with organizations across 15 different counties. And then I have a colleague that takes another 15. And then I have colleagues up and down the state of Indiana. But also I work on the state level with the governor's challenge. I want to tell you what, our governor is absolutely committed to suicide prevention. So the Indiana Department of Veterans Affairs, we partner with them as it relates to building coalitions regarding suicide prevention, or we also connect to pre-existing coalitions. All of the coalitions are not those that are centric 100% on veterans. I'll give you an example. I'm going to give you two examples I think you would find interesting. One of those examples is actually like food pantries. There are coalitions of food pantries across the state. So I would attach myself as a community engagement partnership coordinator on behalf of the VA to this food pantry coalition. Well, why would you do that, LaWanda? I am so glad y'all asked, because I know you're asking, although I can't see your faces, I know you're asking why I would do something like that. Because here we have families, some of them even whose family members are in hospice, some of them whose family members are not, but they may be serving veterans. All of these different organizations are serving those who have served in the military and their families. So we want to be able to have them to be ready and prepared to be able to ask the right questions as it relates to those that have served in the military, and then give them all of the necessary resources that could potentially be available to them. If we have someone that's a family member and they go into a food pantry and they are desiring information as it relates to what potential hospice care or what additional palliative care is available, guess what, you all? We want them to ask that question so they can then know that you all of us, you all are all a resource, because suicide prevention is everyone's business. So we have these different levels. The next portion of this is, how do we make sure that we're capturing, that we're getting the information out to those that are actually served in the military and or their family members? So we have 3 ways that we actually do that. One of those is the identification. As I just explained in that example, we want agencies, no matter what the agency is, to be able to ask the question, have you or a family member ever served in the military? We are asking this question because we know there are some folks who, we used to say, are you a veteran, right? Y'all familiar with that question, are you a veteran? Well, what the research has shown is that everyone does not identify as a veteran. Everyone does not believe, based on the culture, if they didn't deploy here or didn't deploy there or weren't in for this long, they kind of have their own idea of what they think of when they think of a veteran. We all know on this line, though, there are certain criteria that make them technically a veteran. But if we say, have you served in the military? Then people begin to disclose, oh yeah, I served in the military. Oh yes, I have a family member that served in the military. So once the organization, whether it's your organization or another organization that you're familiar with that you can connect me to, ask that question at the VA, we begin to help them to come up with a plan. It's great to ask the question, but if they say yes and you don't know what to do, really, what benefit of that? And so we want to make sure that there is a very good strategic plan for that organization. One, to connect them to the resources that they need and make it a hot handoff so that they are not going into the black hole, right? 2, not only do we want to make sure that they get the resources they need, we also want to make sure that that organization is culturally sensitive to serving those who have actually served. And doing VA SAVE training is one of the first steps for that. But we also have military culture training that they can also go through as well. So that's the first one. The next one is promote connectedness and improve care transitions. For you all specifically, I really see this promote connectedness to be very valuable. The coalitions that we have developed across the state of Indiana, a lot of them are veteran centric. Some are not, but there are others that are. And Amy was the one. I'm just going to bring Amy into this thing. Amy was like, we need someone to write letters. We need someone to color sheets. Guess what? With the promoting connectedness with our coalitions, they're looking for activities to do in this nature. They're looking to be able to go into a hospice setting and say hello to the veteran that has served so that they can still feel that connection as it relates to the veterans. We also have coalitions focused in on the Purple Star Initiative, which are with the schools for those young folks who their parents have served in the military. We're making sure that those schools are ready and available to assist them. But guess what else they want to do? Those children want to color those photos. They want to color those pictures so that we can get them. That's just one example. When Amy said that, I said, this is a perfect match. So there's opportunities to connect your organizations and your agencies to the coalitions right in your home communities in order to continue to serve the veteran and let them know that they are still connected. The last one that we have here is lethal means safety. With our lethal means safety, we actually distribute gun locks, and we also distribute the biodegradable pill bags where you can put all those pills in there that you've got left over at a home, and or we have the ones where you can actually mail the pills back in. So that is one of the ways that we work with and deal with lethal means as it relates to the prevention of suicide. So those are the three-pronged areas. And I hope as I was going through those, you all were thinking to yourselves, oh yes, what LaWanda is saying, that's something that we could benefit from with our organization. So please, I would ask that you join me, help me as it relates to the prevention of suicide, because one life lost to suicide is too many. And so not only are we concerned about the veteran, we're also concerned about others who've served in the military and their family members. You all have a very difficult job, and I just commend you. Somebody's got to do it, and I commend each and every last one of you on this call, because those caregivers sometimes that are left, or they're trying to struggle with and figure out what their next steps are as they're trying to still be caregivers. We want to be concerned about them as well as it relates to suicide. So these are some ways to be able to get involved. I hope that you all will reach out to me. And on that one slide, this is my direct number. So Liz, I want to make sure if you distribute that this number here is the one that they get, because again, I want a hot handoff. When they come to me, I want to be able to be responsive as it relates to suicide prevention for the community. And so with that, the next thing is anyone have any questions for me? And if you don't have questions now, you can always reach out to me and contact me and ask me those questions. But I am out here. I'm in the field. I am not in the building. I have left the building, you all, and I am in the community as it relates to suicide prevention. Any questions? Did I miss anything in the chat? Amy's giving me some hearts. Thank you, Amy. I appreciate the hearts. Thank you so very much. Any additional questions for me?
LaWanda, I have a question.
Yes.
Almost everyone on the call is works at a hospice agency. There's a few exceptions. We've got like some veteran volunteers on the call. Have you ever partnered with a hospice agency that you can recall? And if so, what kinds of things did you all do? Or your energy and presentation was super inspiring. I'm hoping that we get quite a few agencies that reach out to you to connect?
Liz, the answer is no, but I know it's going to be a yes now. That's why I was like, I have not had the opportunity to actually connect with hospice agencies in the counties in which I serve. Now, my counterpart, Dr. Marine, she may have. I don't think so, though, but I would love an opportunity to be able to connect with each one of you.
Great. And we do have hospices from around the region because we represent like the Northern Indiana VA service area and Indy. And I think there's even some people from outside of that, like in Evansville. So you may hear from
Beautiful.
people from different areas. And if it's not you, you can connect them to your
Absolutely.
counterpart.
Absolutely. There is a community engagement partnership coordinator. Listen, y'all, in all of the states of the United States. Okay. So even if you know a colleague that's in Puerto Rico or Hawaii or Mississippi or Alabama, I can connect them as well. But we got Indiana covered. Oh, we got it covered. We are ready and willing to connect with all of you.
Love it.
Thank you, Liz, for that question. Anybody else?
I just want to say thank you. You are very inspiring. I think that the way you have presented this has opened a lot of people's eyes, and it's not a question, it's just a sincerely thank you for on behalf of everyone on this call. I'm sure everyone feels the same way that I do. Thank you for bringing this to light and taking your time to come talk to us today.
Thank you so much, Angie, for being the spokesperson for the group today. I appreciate that. That is my presentation, and I look forward to connecting, and I will be giving information to Liz that she can disseminate out to you all as well. Thank you so much. Without further ado, I'm going to turn it over to the infamous Melissa Weber. Look how Melissa's looking, y'all. Can y'all see Melissa? All right, Melissa, thank you so much.
Thank you, Wanda. I'm not infamous, and I'm mad that I have to follow that up. I should have requested to go first. My energy level's not there. Okay, so I will share my screen. So if I can, share. Okay, are we good?
Looks
Yes.
good.
Looks good. Love to hear it. Let me slideshow. Okay. All right,
Perfect.
everybody. So my name is Melissa Weber. I am a suicide prevention coordinator, as Liz said, here at the VA Indianapolis location. I am going to go through this VA SAVE training with you all. This is put out by our Office of Mental Health and Suicide Prevention. So it is kind of a standard thing. I did try to put some information in here to make sure that it is tailored to patients, veterans, people that you guys might be coming across more often. Okay. So little disclaimer, before we begin here, just letting everybody know that suicide is an intense topic for some. So if this is too heavy for you, if this is a lot, please feel free to step out. Resources are listed here. Obviously, our Veterans Crisis Line is connected to the National Suicide Prevention Hotline. So that is 988. To get to the veterans portion of the crisis line, we press 1 and they will take you to the veteran specific crisis line. Okay. This is also, just as an FYI, I'll go over this at the end, but this is a number like freely to give to people. You don't have to be a veteran to contact the Veterans Crisis Line. If you are calling on behalf of a veteran, it's still the same thing. Friends, family, caretaker, whoever can also contact the Veterans Crisis Line and have a conversation with them. If you need help in maybe kind of figuring out what to do, walking through something, they can help you with that. They can reach out to a veteran if you're not physically with that veteran, but you share concerns. Maybe they sent you a text message or an email or something, and you're like, ooh, and you can't get a hold of the veteran, you can contact them. They can always call welfare checks, things like that. Okay. All righty. So our objectives, well, the overview, we're going to objectives, facts about veteran suicide, common myths and realities, the VA Save steps and resources. Objectives. So at the end of this, oh no. At the end of this, I want you guys to have a general understanding of kind of the scope of veteran suicide within the US. I need you to be able to identify veterans who are at risk, and then know what to do once that is identified. Okay, I can identify that you have X number of risks that you know, that kind of, what do I need to do about that? Like, where do I go from here? So, just to start off, and I want this to kind of be an open conversation. If you guys have questions or anything, definitely you can come off mute, stop me, ask. This is not super formal. You don't have to wait till the end and raise your hand or anything. So if you do have questions, let me know, okay? Off the bat though, does anybody have any specific questions about suicide, talking to people who are in crisis, veteran-centered questions about suicide? I mean, we're going to kind of go through this. You might feel like you don't have questions now, or maybe you do, and you might want to see if they get answered. Okay. So here are some facts. Suicide is a national issue with rising rates of suicide in the general population. So in addition, suicide rates are higher and are rising faster among veterans than any other non-veteran adults. Societal factors such as economic disparities, race, ethnicity, LGBTQ plus disparities, homelessness, social connection and isolation, health and well-being play a role in suicide. Just as a note, the COVID-19 pandemic has also placed an additional strain on our nation and on individuals and communities. So I know that that has kind of been taken down a little bit, but I think it's still worth noting that the impact, and we're going to still feel that for a while, the impact that has had on our nation in general. So our nation grieves with each suicide. It's prompting the collective tireless pursuit of evidence-based clinical interventions and community prevention strategies, okay? Just like LaWanda said, one suicide is one too many, okay? Think about, you can kind of think about it like the 6 degrees of Kevin Bacon, right? We've all been touched in some capacity to suicide, maybe not veteran suicide, but to suicide, okay? Here is some data. So I know that, I don't know that. I'm going to assume that most of you have heard like the 22 a day regarding veteran suicide rate. It's no longer 22 a day. It's at 17 and a half. That's the average number of veteran suicides per day as of 2021. Okay, that's the most updated information that we currently have. So yay, number going down, but also no, too high. Like that's still too high, right? So the actual number of deaths is here over 6,000. Okay, and the rate is 33.9 per 100,000. Okay, it's high. It's high. I mean, I don't know how many times I can say that. Probably a lot. We're trying to close the gap. These efforts that we're doing, LaWanda, suicide prevention coordinators at all VAs, people who work in the community with suicide prevention, un-VA related, we're putting in the work to continue to decrease these numbers. It's preventable. It is. So complex issue with no single cause. So generally, people who feel that this is their option, there's a lot going into that for them. So again, risk and protective factors exist. People who are at an increased risk, they don't have enough protective factors to kind of even out that risk. If they, let's say you're checking boxes and you've got 5 risk factors, but they have 1 protective factor, that's not a good, I'll say percentage. That's not a good mashup, unless sometimes their protective factor may be huge. Children, religion, spirituality, things like that, that really, really protect them. Spirituality is a big one. I won't commit suicide because, my belief is that I would go to hell, right? That would be a really big protective factor, for somebody. So here's just a brief list of risk and protective factors to kind of give you an idea of what these can look like. So in terms of risk factors, so these are just associated with an increased likelihood of suicidal behavior. So prior attempts, mental health conditions, access to lethal means, and really think outside the box what that looks like sometimes. What can somebody actually harm themselves with? I mean, obviously you have like firearms, things that are going to be pretty clear that they can be harmful, but there might be some other things that you may not think about. People have knives in their drawer every day, and you think of it as a regular utility thing that you just use. But if somebody's at risk, that may be, a problem to have in their home, just to even have a knife if that is of concern. So protective factors are the things that offset these risk factors. So things like access. Do I just have access to mental health treatment? Physical health treatment? Do I have a good relationship with the people that are providing that care for me? Is it just good enough to say I have a therapist and I go to therapy? Well, what's your buy-in to that? Do you have a good relationship with them? Things like that matter. Again, I said spirituality, having a purpose. What am I here for? Do I feel like I am serving a purpose to my community, myself? What does being a productive member of society mean to me? And am I doing that? That's meaningful to people. So when you think about some people who have, mental health related issues or physical health related issues, isolation is a big risk factor for them. How are they feeling connected? So are they losing their sense of purpose because they can't get out of the home? Nobody comes to visit, or things like that. And I know that I've had veterans who don't have people in their life that they feel connected to, other than maybe that home health nurse that comes in 3 times a week. And they look forward to that hour that they get with their home health nurse, because she's nice and she talks to, and like things like that. And they just really live for that. So you never know who you are to somebody sometimes, access to lethal means is our biggest risk factor. Okay. Here is a graphic to show you, just kind of given our top methods here, or means, firearms, poisoning, suffocation, and then other. So our biggest piece of that pie is going to be our firearms. Okay. That is our most lethal method. And it's high here. Very clearly, you can see, for veterans and non-veterans. So U.S. veterans, and suicide status, so sex and age groups. I kind of clipped this out a little bit. I feel like given the who I'm talking to, given you guys working in hospice, I kept the age group 55 plus. I'm sure that there are young people that you see, but for the most part, I think 55 plus kind of captures the population, the age of the population that you guys are serving. Okay. So here are the numbers broken down to, you've got from 21 to 2023, or I'm sorry, from 2001 to 2021, my bad, I'm sorry. you're different. You got age 55 to 74, and then you got 75 plus. You've got veterans, non-veterans, male and female, and the numbers, the percentage of numbers that exist there. Deaths, this is deaths. All right. Again, these are really high. I mean, firearm in 75 plus veterans, I mean, 86.5. I mean, that's the majority, right? So those numbers are startling. I will say our biggest risk age group are going to be your younger, so 40, maybe 35 to 50-year-olds, white males, veterans. That's your highest risk group in general. So integrated suicide prevention within medical settings. So I think this is important to note as well, that nearly 40% of recent veteran VHA users, so veteran health users who died by suicide in 2021 did not have any mental health or substance use diagnoses. Many veterans will also never seek mental health treatment. Further, medical conditions, including those lasting 1 year or more, can increase an individual's risk for suicidal behavior. So for example, individuals diagnosed with cancer have approximately 1.5 times the general population's risk for suicide death. So while patients with a poor prognosis have 3 times the risk for suicide death than cancer patients overall, there's a strong association between chronic pain and suicide. Prior research has shown that 45% of individuals who die by suicide have had a primary care appointment in the prior months. So the incorporation of suicide prevention into medical settings is critical part of the VA's public health approach to veteran suicide. So that's part of LaWanda as well, pointing out that these community partnerships are so important. And we have good, through our Compact Act stuff, initiatives, we are getting good relationships with our community hospitals too, working with them. They know to contact us if a veteran shows up to their ER, like, hey, it's not just about getting paid, although as mentioned earlier, money makes people do things, right? So that is an incentive for sure, but also making sure that those people are getting the appropriate follow-up. You know, if you live in Greene County, you're going to your local hospital probably to get treated. If you're having a mental health crisis, you're probably not coming to the Indianapolis VA. So it's too far, but they can contact us and we can make sure that that veteran gets the appropriate follow-up. So that's important. So lethal means safety. So in the context of suicide prevention, safe storage of lethal means is any action that builds time and space between suicidal impulse and the ability to harm one's self. So this next slide will really, most suicidal crises are brief. So time from decision to action is less than an hour. So the more time you can put between that person and their means will be helpful, okay? While some suicidal crises do last a long time, most do last minutes to an hour. So one study of suicide attempt survivors, 47% said it took less than 1 hour between their decision to attempt suicide and their actual attempt. 24% said it took less than 5 minutes. So time between when a person decides to die by suicide and the act on the decision is short, okay? 71% of attempters estimating that the process took less than an hour. This reality underscores the importance of reducing access to means for those who are at an elevated risk. Again, lethal means safety works. So I already kind of gave you these numbers. 90% of people who survive a suicide attempt do not go on to die by suicide. So subsequent attempts are low. People will I regret my decision. I realize now, what that meant by trying to do that. So if we can get them to think about their actions and behaviors beforehand, can we lessen the thought that that is, the right choice for them to make in that time? So just some global numbers. Australia instituted stricter gun safety measures, including minimum age restrictions, psychological evaluations, background checks, and waiting periods. The firearm suicide rate steadily declined by 4.7% each year. In Israeli, they saw a 40% reduction in the suicide rate among their soldiers when they restricted soldiers' access to firearms during leave, specifically like their weekend leaves. So firearm related suicides in Indiana and Connecticut declined after we enacted legislation allowing law enforcement officers to seize firearms from individuals they deem a risk to themselves or others. So in thinking about facilities, if somebody's in a facility, there are obviously certain restrictions to that facility of what they can take in with them. I'm going to safely assume that firearms are not it. I can't take your firearm into the facility. But then what becomes unsafe in their living space? So hospitals think about this. I'm sure facilities have their own policies regarding what they do for if somebody is kind of at a higher risk of suicide, what they allow in their room, what that looks like, lunch trays, whatever that may be. And then when you think about people in their home, access looks a lot different. It's their home and they have kind of whatever they want there. Do they tell you that they don't own a firearm? Like, okay, what else do you have in your home though? So that kind of goes back to like that kitchen knife thing. You would just kind of assume, okay, well, they have a knife because they're putting butter on their toast in the morning. But is that knife something that they have thought about using against themselves? Excuse me. So suicide is preventable. Myths and realities. Does anybody have any possible myths off the top of their head that they think, well, I've heard this about suicide, but I'm not sure if it's accurate? Because there's a lot of misinformation out there about suicide. So people who talk, oh, go ahead, Mark.
I was just gonna say, I know with this group here and specifically, you think suicide and hospice, they're dying anyways, and it definitely still can happen. So yeah, I think that's a myth, kind of misinformation. I don't know what you call it, but that think, well, they're on hospice, they committed suicide, they were dying anyways. Well, it's still suicide, and
yeah.
And we're here for comfort for life's final journey, not suicide. So yeah.
Yeah, for sure. And I'm sure that I'm sure there's a lot of hopelessness that kind of exists there for some people too. And as you just said, kind of helping people on that journey. That's really important. I'm so proud of the work that you guys do like that. I think like, oh man, sitting with somebody, in that space in those last moments, sometimes, I think that would be really hard. So good for you guys. So people who talk about suicide are just seeking attention. I mean, that's a myth, right? No matter how casually or jokingly said, suicide threats should never be ignored. There's truth in most things people say. They might just be testing the waters. If I kind of like put this out here, what's the response going to be? Do people care about me? If I say something and it gets blown off or not treated seriously, they must not care, right? That could be the thought of somebody. So if anybody ever alludes to or says something about it, taking it seriously and making sure the appropriate follow-up makes sense. The only one who can really help someone who is suicidal is a mental health counselor or therapist. False. Everyone can. Okay. So you don't have to go to school forever or have a license or whatever to be able to help somebody who's in crisis. So as this said, heartfelt support can also make a big difference in a challenging time. People don't feel heard. They don't think others care. This is, what a space to be in, to think that suicide is my way out. Like that is what's going to get me from the pain that I'm experiencing, the physical or mental pain or both. So here is the VA SAVE. So we love acronyms at the VA. So this is another acronym. We'll go through it. It does kind of make it easy to remember, but at the end of the day, it is still another acronym, and that's what we do. I tried to kind of eliminate the acronyms out of this presentation, but we can't get away from this one because it is what the presentation is, okay? So SAVE stands for signs of suicidal thinking should be recognized. Ask the most important question of all. Validate the veteran's experience, encourage treatment, and expedite getting help. So we got 2 E's. So it's like SAVE E, okay? To go through these signs of suicidal thinking. So these are some of the warning signs. They're listed here. This withdrawing, isolation, I mentioned that earlier. If you can't get out of the house for physical health reasons, or you're depressed and not able to get out of bed, and you stop talking to people and stuff. I mean, that's a big sign when people start cutting loved ones off, or you just haven't, hey, I haven't seen Joe in a while, he hasn't come down for breakfast, or, whatever. Engaging in risky activities. So the impulsive behavior, driving fast, spending money, things like that. Increased substance use. I think that one could probably kind of makes sense. Feeling like there's no reason to live. Anxiety, agitation, sleeplessness, and mood swings. I mean, how do you feel when you don't sleep, right? If I only get a couple hours of sleep, I don't feel great. And for some people that's on end. And there are things that we can do to help that. There's so many things that can help these risk factors. So the presence of any of the following requires immediate attention. So if somebody's actively telling you that they are thinking about hurting themselves, they have had thoughts, they're thinking about how they're going to do it, they're thinking about a method, they're making any sort of plan on what that can look like, and they have intent to do it. I think that this is what I'm going to do. And then, in the context of substance use is kind of a big one. If somebody has, let's say they abuse alcohol, and a lot of these behaviors show themselves when they're using, but not when they're not using, that's still something to consider, that even though it's in the context of a substance use or alcohol use, or risky behaviors in the context of that, it's still important to note and think about any other risk factors that might exist as well. Because there's a lot of people that they will get drunk and take a bunch of pills or something, and then they come in and they regret it. I didn't know what I was doing. I didn't, they weren't intoxicated, and they didn't know that they did those things, and they can't identify if they had intent to die at that time. So those situations need to be taken just as serious as somebody who can say, I did intend to die. So asking the question, know how to ask the most important question. What's the most important question? What do you think? Are you going to kill yourself? Do you have thoughts about killing yourself? Do you have thoughts about harming yourself? Do you feel suicidal? Like it's just, I know that sometimes when you're in a situation with somebody, it feels a certain way to be like, hey, have you had any thoughts of suicide? Have you had any thoughts of harming yourself or killing yourself? I know our older population too tends to be like, why are you always got to ask that question? And quit asking me, I'm fine. And, you know, like they have thoughts about you having thoughts about them harming themselves. But I mean, they're gonna, if you ask and you're consistent about it and you show you care about it, they're not going to be mad at you for asking it. You know, I know it's just part of the drill. You know, I know that you need to ask, stuff like that. Kind of breaks the ice a little bit with them. But we have to ask, and we can't be afraid to ask, and be very direct about asking and not leading. You aren't thinking about hurting yourself, right? Like, that's not how we ask the question. That's not how we ask the question. So that's right here. It's not asked kind of haphazardly either. Like, it's not a flippant question. It's serious. And so we're not doing it like, oh, I forgot to ask, are you having thoughts of suicide? You know, like it's important. Eye contact. I'm talking to you and I'm asking if you're okay. So definitely using the direct phrasing. So validating their experience. So let's say they say, I have thought about that. Okay, well, what does that look like for you? Are you open to talking to me about your thoughts and your experiences? Listen then, like if you're gonna follow that up, make sure you're listening when they do talk to you about it. So this is a serious situation. We're not passing judgment. We're reassuring them that help is available. Help is available. If you work in a environment that has those supports that exist just organically in your organization, great. As somebody who works for the VA, if it is a veteran, even though you have those supports in your facility, we would still like to know that that veteran is having those experiences and those thoughts in your care, and we can at least follow up. If the veteran is getting therapy or some services, whatever, through your organization, that's great. But we want them to know that we also exist for anything that they may need supplementally if they're already receiving care, okay? Encouraging treatment. So now we've offered treatment. Okay, you know, encouraging it would be the next step to that. How are we making them feel safe to get treatment? So many people don't want, I mean, they're told to suck it up and not say anything. And so many veterans come out of service feeling like they didn't have a space to be able to have some of these tough conversations about the thoughts and feelings that they're having. And then they feel like the VA is going to tattle. The VA is going to it's not going to be a good look for them to come to the VA and get assistance, or anywhere to get assistance for that matter. So, hey, we just want to help. You know, we're not here to take your guns. We're not here to lock you up. We're not here to do those things. We're here just to make sure that you're safe. So what does that look like for you? What can we do? If they are actively suicidal, we don't leave them alone. If you catch them engaging in suicidal behaviors, we don't say, hey, let me leave you in this room and let me go get somebody. The veteran can come with you. You can sit with the veteran. Again, if you're in a facility, hopefully there are access points in rooms that allow you to connect with help without having to leave a room and leaving a patient and or a veteran there. We aren't making promises to anybody either. We're not keeping secrets. Oh, don't tell anybody that I had these thoughts. Well, I'm not going to promise you that I'm not going to do that, because if you are in danger, I do have to tell somebody. Okay. Here it notes, the doctor, emergency room, veterans crisis line. These are all good options on where to get a veteran help if they're actively in crisis. At the VA, we have mental health clinic walk-in availability every day, Monday through Friday. Veterans can walk in, they can be brought in to the mental health clinic for any sort of assessment or care. Outside of that, Our ER is available as well for anything after hours, weekends, holidays, and your local ER. Veteran just has to come and say, I am a veteran, and they will coordinate care with us at the request of the veteran or not, if the veteran doesn't want coordinated care. So when talking with somebody, specifically a veteran who is at risk for suicide, open body language. So that signals interest in the other person and the conversation. Maintain a relaxed posture, lean in closer, direct eye contact, nod in agreement to let the veteran know that you are present in the moment with them. Okay. Again, be honest. Let the veteran know there are no quick solutions, but help is available to them. So here is the VA SAVE right here. As I noted, it is an acronym. It stands for signs, ask, validate, encourage, and expedite. So that's how you can remember. It's kind of like when you think of like, oh, the fire, like pass and race in terms of like fire safety too. So these are just a few quick resources, references and stuff. We have VA SAVE training online. You can at any point in time access this. Anybody can access this at the Psych Armor Institute. So that's always an option if you feel you need a refresher, you want to share this information with anybody that you may work with or your organization themselves. Veterans Crisis Line, as I mentioned, it can be anybody here. I mean, veterans, active service members, family members, friends, caretakers, anybody can contact. Here's just kind of a history of the crisis line. This just kind of gives the information on how this looked, who and how many people that they are really serving at the Veterans Crisis Line. You can access the Veterans Crisis Line, I'm also going to mention, via chat and text message. So those are also options as well. If somebody doesn't have the availability of a phone, or it needs to be more discreet and having an actual like audible conversation isn't available. Find your local VA SPC. That's me. You don't need to go to this resource locator. You can just call me and I will connect you. Much like Lawanda said, we can connect you to any other VA that's in your catchment. There are suicide prevention coordinators all over the state. We have good working relationships with the suicide prevention coordinators in our surrounding states as well. Illinois, Michigan, Ohio, Kentucky. We work well with a lot of them because we share, like Terre Haute, we share a ton of patients with the Danville VA out of Illinois. So we know these other staff and we talk to them. So if you need connected with anybody, you just call me and I will tell you the right person if it's not me. Resource locators. So again, this is just being able to go to the Veterans Crisis Line. You can put in where you live, what resource that you're looking for, and it gives you information on that. This is another reach out is our current, it is Suicide Prevention Month this month. And our, in an effort to make sure that everybody is knowledgeable about what suicide prevention awareness looks like. So it's this don't wait, reach out. We really want people who are involved in the veteran's life to know what they can do to be able to help the veteran. We have focused really hard on veteran safety and engaging the veteran. And now we need to make sure that we're including everybody else in their life. So again, that's everybody on this call, friends, family, anybody. If you live with, work with, in any capacity, a veteran, know anything, then you're somebody who can help. There we go. Make the connection. So this is a video. Oh, it's going to play. I don't need it to play. It is a video with veterans just talking about their experiences regarding mental health, them getting help, and kind of what that has looked like for them. So their personal stories on that. So I definitely want to spend some time talking about the options that we have here. Lawanda has touched on these, and I need to emphasize it. Gun locks and pill disposal options, we will give to anybody who asks, okay? We, VSOs, routinely, veteran service officers in every county routinely reach out to us. They ask for gun locks, they ask for pamphlets, information, anything to be able to provide to their veterans. It's not just the VSOs that we, although they're routinely asking for stuff, we'll give it to anybody. So if any of you work at a facility and you want to have this information available to any of your veterans in your facility, we can provide that to you. If you're working in home services and you know that veteran has 3 guns and they're under his pillow or something, gun locks, hey, call me. I'll send you some gun locks for your veteran. I'll send them directly to the veteran. I'll send them to you wherever you want them to go. You let me know. We want to hand this stuff out. We're not trying to take firearms. We want to make sure you're safe with them. Okay. Same thing with the medication bags, which I think is in here as well. We have the brochures with all the information on it. So this is some LGBTQ plus information. If this applies to any of the veterans that you guys serve, we have a really, really, really good program. People from all around the US engage in our LGBTQ plus services at our VA. They'll do it virtually, whatever, groups, support, all healthcare, all sorts of things that we offer. If you know a veteran that you think that you work with that may benefit from any of this, you can let me know, you can let Liz know, okay? And we will make sure that they're connected to this resource at our VA. There's apps, depending on how tech savvy your veteran is, we have apps. These are easy things that they can pull up in the moment and utilize to be able to be a part of their toolkit in helping with their mental health. So we have PTSD, MST is military sexual trauma. We have a program at our VA for that. Insomnia coach. I mean, that's a big one. Remember the sleep. I don't feel good when I don't sleep. So this is, I know a lot of veterans that use the insomnia one and the PTSD coach and the mindfulness coach. We have a safety plan app. I don't know how often you guys are safety planning with your patients, your veterans, in the context of hospice related care. It's always good to have a safety plan. Doesn't have to be a formally written up document, although ideally that is what it would look like, but having the conversations with them about how they can keep themselves safe, what is triggering for them, what they can do in the moments when they have those thoughts, who to contact when they're having those thoughts, and who their safety contact is. That's beneficial for not only them, but for the caretaker as well. So this specific app can really create a custom step-by-step action plan to keep the veteran safe during any sort of crisis. So again, this would kind of be for your tech savvy. If they're not writing it out, it is always best. Hang it on the fridge, put it at the nightstand, whatever they need, and whatever makes it more accessible for them. Go over that. So this is postvention resources. So we have a postvention team at our VA, suicide prevention coordinators that work with families post-suicide. So if we learn of a veteran suicide, we contact the coroner, we contact the family, we offer resources. There's a national resource kind of debriefing that's offered through MyRec VA, MyRec VA services that will have a conversation with the family kind of about what led up, how they're feeling, what they need. So we have a lot of different options to help support families. So if you're in the position that maybe this is the case for one of your veterans, you can receive service. So we do offer some kind of brief, I'm not going to call it therapy, but it can be a traumatic event to have somebody in your care complete suicide. So you will probably need somebody to talk to about that. So we offer that. It's not just family, it can be for the providers as well. This is a repeat slide through the Psych Armor Institute, being able to do the VA SAVE training. So that is the end of my presentation. Questions, comments, concerns? I didn't see the chat, so I guess look at it now.
I think the only question that dropped in was actually mine, and I think you really did a good job of answering it. But I think what comes to my mind a lot with suicide is people sometimes say, well, if the veteran has made up their mind, there's nothing you can do about it. That's a hard one for me.
That is hard. And I understand why people think that. But I'll go back to the data on that one. People, 90% don't repeat attempt. Okay. And I don't have data in this slide regarding, like, you know, how many attempts and then how many of those are lethal. Just the straight number that are lethal, not versus how many attempts. But if it's firearm is the most lethal. I mean, if you attempt suicide with a firearm, you are most likely going to harm yourself significantly. So outside of that, though, people are, you know, if they OD and they come to the hospital and they're saved, I mean, they have time to think about what that looked like for them. And again, they're part of that 90% that aren't repeating. But that's why the firearm safety is so important, and putting space and time between lethal means. And I'm kind of harping on the firearm again because it's so lethal, but in general, like, let's say it's pills. Let's say they take a lot of medications, right? A lot of medications that could really hurt them if they take too many, even if it's accidental. Having somebody be in charge of their medications, kind of doling out those medications, nursing staff or even family members, putting that time and space in between is what's really important, because it gives them time to think about, as I mentioned earlier, like, it's just as sad for me to think that somebody's in a position that this was the option for them. So thinking about how we got there and how can we work on what that felt like, and if it, let's say it's depression, you know, that's why treatment is so important. Like, let's help so that you don't feel so hopeless that this is your space to be in. So I can understand why that is a thought process for a lot of people. But I'm still going to argue that it's a myth, because it is preventable.
Yeah, I agree. And to Marty's point, like, we are all here to try to improve the quality of life for our veterans at end of life.
Yes.
And their mental health is a huge, if not the greatest piece of that. They're losing their physical independence and so many other things. So constantly assessing for their mental health needs and suicide risks is so important. We really appreciate you guys reaching out. Just in the essence of time, we'll have to cut things off, but I will make sure that everyone has LaWanda and Melissa's contact information for any follow-up questions or any requests you have for some of the resources they mentioned. It sounds like they would be happy to mail out to hospice agencies gun locks, brochures. They have like wallet cards and fridge magnets with the the crisis line. Just any of the things you heard mentioned today, don't hesitate to reach out to me or directly to them to request that information. Don't forget that the VA palliative care teams have mental health support, even virtually, in person or virtually. I dropped in the chat and we will resend kind of a information sheet on how to request mental health services through palliative care for veterans at end of life. I'm just was blown away at how much I learned from each of the presenters today. And it just makes me think like we can never do enough education on suicide prevention. And I appreciate the time and interest of all of you in being here today. They knew the topic and they turned out today. So please share these resources with your teams. We will make sure to send out kind of a summary of what was presented today and post that on our website. So please, again, share this with your hospice teams, and especially that staff who's on the ground out there in the field taking care of our veterans. And I loved what LaWanda said about when we're screening, asking, were you ever in the military? Is anyone in your family in the military? I kind of like that. Our hospice agencies do screen for veterans, and maybe that's a way we could change that to capture more people. So thank you everyone so much for being here today. We appreciate you all, and we will see you at the next quarterly meeting. Okay, thank you so much.